Did you know that Alzheimer's disease is currently ranked 6th leading cause of death? And it's also the only leading cause of death that is not currently preventable. Also, between 2000 and 2015, deaths from heart disease have decreased 11%, while deaths from Alzheimer's have increased by 123%.
Hi, this is Dr. Jonathan Youssef, Networking for Your Optimal Health. Today's topic is going to be about dementia, Alzheimer's, and essentially we're going to talk about aging elderly patients that need our help. And with me today is Shelby. She is from South University, a PA student with me, and has had some great experience with this topic. So I'm going to have her share with us some of her knowledge on this. So without further ado, Shelby.
Hello. So the first thing I want to talk about is just dementia in general. It's a pretty common misconception that Alzheimer's disease and dementia are interchangeable terms when in fact they're not. So dementia is actually an umbrella term that describes a collection of symptoms that are caused by disorders affecting the brain. Dementia affects thinking, behavior, and the ability to perform everyday tasks. And it's when they're severe enough to interfere with a person's everyday life that it's known as dementia. Some of the things that fall under that category are Alzheimer's disease, Lewy body dementia, vascular dementia. There's a whole host of them, 50 to 100 different types, but Alzheimer's disease is the most common one, accounting for 2/3 of all dementias. So getting right into Alzheimer's disease and what it actually is. So it is a progressive, irreversible, and neurodegenerative disorder of the brain that affects memory, but also at least one other aspect of cognition. Anything from language to motor ability to the ability to recognize objects. And then, of course, executive function, which includes planning and judgment. Most people fall into the late-onset category of Alzheimer's disease, which symptoms can start as early as mid to late 60s. The cause of that being a combination of environmental or genetic factors. But then there's also early onset, which symptoms can appear as early as the 30s. And that tends to be more genetic or familial. So going into the pathophysiology, actually a whole lot is not known about the pathophysiology of Alzheimer's disease. It's not really that understood. But in general, it is a loss of neurons, the cells of the brain, over the course of time. And where it affects the neurons most is in the cortex, which the cortex is responsible for thinking, information processing, making decisions, and ultimately what makes us us. So what separates Alzheimer's disease from other dementias is the presence of plaques and tangles and their correlation with disease progression. In a normal functioning neuron, there are actually transmembrane proteins called amyloid precursor protein, or APP, which function to repair a neuron or help existing neurons grow. And as these proteins get used time and time again, ultimately they need to be broken down and recycled. So what happens with that is that when it comes time for this APP to be recycled, a group of enzymes called secretases are responsible for breaking it down. And it all comes down to the perfect combination. So in an ideal world, you want the alpha secretase and the gamma secretase to work together, because when they cleave the protein, it creates this soluble monomer that can break down outside of the cell. But it's when the gamma protein and the beta secretase work together that just the combination of the two creates for a unsoluble monomer, which we know as the beta amyloid, which is a sticky monomer that when floating outside of the cell, they all like to stick together and clump, creating these amyloid plaques that we have come to know.
Okay, ask why some people might have that and why others would not? Like, is there a genetic predisposition for it, or is it unknown to this day?
So there is a genetic predisposition, there can be, I should say, but less than 1% of all people with Alzheimer's have a genetic predisposition for it. It's honestly hit or miss in regards to the amount of amyloid that builds up outside of the cell. But over time, it's the buildup of amyloid across all different cells and the actual inflammation process that amyloid protein triggers that causes destruction of other neurons.
I've heard of a condition called amyloidosis. Is that somehow in relation to this? My understanding is that they're really not linked, but it does sound like the same molecule, amyloid, that causes damage. So hopefully we'll figure this out in the future, and that will be something to help us in our research for it.
No, I mean, that's very interesting. But then, the amyloid proteins are one aspect of Alzheimer's, but then you also have something known as the tau protein as well, which is another buzzword in association with Alzheimer's disease. So the tau protein is what's on the inside of the neuron. So
This is all happening in your brain only and not other areas of your body? Because I've heard that Alzheimer's just affects the nervous system as well as the brain. But like from what I understand, people from just having dementia will have multiple medical issues, not just from memory loss, which seems to be one of the biggest hallmarks of the condition.
Yeah, and it's just affecting the neurons. It all depends on the type of dementia that you have. Alzheimer's has the plaques and the tangles. You have Huntington's disease, which is also another type of dementia that's genetic, and it has to do with loss of motor control. And so ultimately it's with the neurons in the brain. This tau protein as well is the big stabilizer for the microtubules or the highways of the cell. And when those get changed somehow, which scientists don't know how they get changed exactly yet, they also start to break down the microtubules and clump together, creating the neurofibrillary tangles inside the neuron. So with that being said, the communication ultimately from between different neurons and inside the neuron itself get disrupted, and the neurons undergo apoptosis, which gives the brain that characteristic shrunken appearance over time that is known with Alzheimer's disease. And one of the first places that damage occurs is in the hippocampus, which is what we know as an area important for formation of memories. So, talking about risk factors, I know that's a pretty common question, especially when it comes to genetics as well.
Absolutely.
Again, no one really knows a lot about the exact causes, but one thing for sure is that increasing age is the most important risk factor. So, epidemiologic studies of Alzheimer's disease and other types of dementia have found that the prevalence increases with age from 14% in people ages 70 or older to more than 25% in people over the age of 80. About 1/3 of all people age 85 and older will have Alzheimer's disease. And other factors include being a woman. Women actually get it more than men do. And then also head trauma, hyperlipidemia, hypertension, diabetes, stroke, smoking, and periodontal disease have also been shown to increase risk. In the aging population, though, a good sign might also be if your practitioner has already told you that you have signs of mild cognitive impairment, which is a common precursor to Alzheimer's disease. In regards to genetics, though, like I said earlier, it's less than 1% of people who have Alzheimer's got it or inherited it. What scientists most often look for is a gene called APOE4 gene, and that's what can be tested through blood test, but the blood testing itself only happens if you have a confirmed diagnosis of Alzheimer's disease. And it's often most associated with early onset Alzheimer's.
Is this for the children or the family members of someone with Alzheimer's? Can they check that gene and see if they have it?
They can, but there is a lot of controversy in whether or not to do it early. Along the same lines of, would you want to know that you're going to develop Alzheimer's? It's the whole ethical debate of it.
I wonder if we had better treatments, wouldn't that actively getting treatments early would be one of the reasons to do some testing like that? I haven't seen anyone in our office have a test like that, but this is actually my first time finding out that there is a genetic test that can help us with this.
Well, there is testing. I'll talk about it later.
No, that's fine. No, we'll kind of like follow up with the testing for sure. But I think I maybe jumped the gun a little bit because this is kind of an interesting topic, and I'm sure a lot of our listeners wanted to figure out if they're should be tested or not. But yeah, please. I think symptoms were where you wanted to go with this one.
Yeah, so symptoms, I think, are probably one of the most talked about aspects of Alzheimer's disease, especially when you're worried that you may end up getting it. So all the following information that I have, or that I'm going to share with you, all came from the Alzheimer's Association website, which they are a great resource and really lay it out, because one of the most common questions is, how do you tell the difference between just regular forgetfulness and if you have Alzheimer's disease? I have been told before, someone has said to me that it's not forgetting your keys, it's forgetting what your keys are that is the difference. And so just comparing some symptoms. So the most common early symptom of Alzheimer's is difficulty remembering newly learned information. So it's forgetting important dates or asking the same information over and over again, and depending on family members or friends to remember those things. It's totally normal, on the other hand, to forget names or appointments, but then remember them later. Another thing, changes in the ability to develop and follow a plan. So people with Alzheimer's may have trouble following a familiar recipe or keeping track of monthly bills, and they may have difficulty concentrating or take longer to do things than they normally did before. The normal comparison is just making occasional errors, like when you're balancing a checkbook. People with Alzheimer's often find it hard to complete daily tasks. They may have trouble driving or remembering the rules to their favorite game. Normally, in normal aging, needing help to use the settings on a microwave or recording a TV show is common and very typical. Another symptom may be a person with Alzheimer's disease may put things in unusual places, or they may lose things and be unable to go back over the steps to find them again. And then in normal aging, misplacing is pretty common, but you're able to retrace your steps and find it again. You also, with Alzheimer's, notice a withdrawal from regular activities, and in addition to inability to remember how to do those hobbies or activities, things that you once loved. Whereas older people, they'll continue to do their normal scheduled routines, but become even more irritated when those routines changed. And those are kind of the early symptoms that you may notice. But as progression of the disease occurs, you may also notice disorientation, extreme mood and behavior changes, personality changes, deepening confusion about events, time, and place, and unfounded suspicions about family, friends, or caregivers. And that towards the end, it's even difficult to speak, swallow, walk. And also are very common to see Alzheimer's patients wandering around, which is a safety concern in itself. The thing that they're discovering more and more as of recent is that Alzheimer's actually begins maybe a decade before the symptoms actually appear themselves, which makes it so hard to diagnose early and to treat.
May say that one of the things that we notice in the office is when patients come in with just simple memory loss, and then they're asking, is this a sign of Alzheimer's? Is this dementia? Or is it just simply memory loss? And I start thinking about actually treating those patients extremely early, since we don't have any clear diagnostic testing we can do. And I treat them early. There's a lot of natural products that could be used, but the reason I bring it up is that, knowing that it's a decade early, it wouldn't hurt for you to be a little bit aggressive with them, because once those symptoms set in, it's really hard to reverse or even delay or slow down the progression.
Exactly. The only true way to actually diagnose Alzheimer's disease is with a brain biopsy, and that can only be done after the person has already passed.
Yeah.
So.
Yeah. I mean, that's kind of, a situation where we've got to do what we have to do, be more proactive in regards to it, because if you're not, then you're not able to treat the patient when they're in severe cases. And so when patients come in and they have an elderly parent and they're just saying they've got memory loss, and they're in that age group where I think that it's the early signs of dementia or Alzheimer's, I'm talking to them about medication, I'm talking to them about supplementation, I'm talking about exercise, I'm talking about preventative or helpful treatments that we think, or studies that have shown to show some improvements.
And that's great. That's ultimately what it comes down to, is since there is no, according to the United States Protective Services Task Force, there is no benefit or harm. It's actually very, the results are inconsistent. There's no standard recommendation of when to screen or to even screen for Alzheimer's or dementia. So it is entirely based on clinician suspicion and the history taken from family members or caregivers, because someone who is affected most often is not going to be aware of it or telling you the symptoms themselves. So as much as 29 to 76% of people with Alzheimer's go undiagnosed, just simply because there is not a standard for screening. But as of 2011, Medicare actually added detection of cognitive impairment to the new annual wellness visit benefit. And so they have been trying to implement that into annual wellness visits. But what you can screen for is mild cognitive impairment. So in my own experience during my internal medicine rotation, we had a lot of people who came in complaining of memory loss or worried that they were going to have Alzheimer's. And what the office did was use either a mini mental status exam, or they had the sheets that a patient could fill out called the Montreal Cognitive Assessment, which is what we most commonly used. The cognitive test for mild cognitive impairment, the benefits being if they come back positive as having Alzheimer's, which is anything less, or it is anything less than 20 that someone is more likely to have Alzheimer's disease. That's when the benefits of screening start to show, because you can start the treatments early. The problem with starting treatments early is that the two main drug classes that have been FDA approved do have side effects, and it's a cost-benefit discussion as to if you can handle those potential side effects for long term, because once you start someone on the medication, the idea is that they are going to be on it chronically.
Could you, if you're going to go through treatment, I don't want to ask this question, but I'll wait for that, because I'm sure a lot of people asking in their heads, what are those side effects that are concerning? But we can wait for that treatment portion to explain to us more.
Yeah. So the last thing about in regards to diagnosis is it's blood test and any kind of radiology type test, whether that be MRI, PET scan, CT, those tend to be after someone has been diagnosed and they've had it for a while. And that's just more of a monitoring of the progression of the disease. Other than that, it doesn't really tell you much.
When you're thinking about diagnosing them and the radiological testing, some of my patients are asking that, well, how do you know that's what it is if you don't run these tests? Is it necessary to rule out these conditions with an MRI or a CT and EEG and all of these tests, or is it something that you can feel comfortable or confident with just using your clinical judgment?
So much of an Alzheimer's diagnosis is based on the presentation and the history. When the MRI and CTs come into play is when you're trying to rule out other potential causes. So other causes being, in general, a patient could be on a slew of different medications, and their interactions with one another can make them more forgetful or irritable. But you're ruling out tumors or other reversible causes of dementia with the radiology scans.
So there was a brief time, probably in the early 2010, 2011, when I started hearing about anecdotal evidence that certain statins were causing cognitive impairment. They since have made a few studies that have disproven this. However, I do still have occasional patients that complain that certain statins might be causing some cognitive dysfunction. I just ask patients to look at their medication list. There's probably many medications that can cause you to have some depressed moods and fatigue and other symptoms that may mimic or seem like Alzheimer's, but it's really just side effects to medication. So consider that too when you're diagnosing it or figuring out if there's an alternative cause.
Exactly. And so getting into the treatment of Alzheimer's. So I was completely unaware as to how just much damage Alzheimer's has done, and it's not necessarily talked about, but it's currently ranked the 6th leading cause of death. Only leading cause of death that is actually not currently preventable.
Yeah, so, just from my own personal experience on this, I worked in a hospice. When I was doing my residency, I had a short stint where I worked with hospice patients, and it turned out that dementia and Alzheimer's was one of the end-stage results of this condition were enough to push a patient towards hospice. In other words, they didn't have to have a cancer or a heart issue or end stage, what you would normally typically think of a terminal condition, but this condition was major diagnosis in treating these patients and figuring out if they should go to hospice or not.
Right, and what's even more staggering to me is I watched a TED Talk on Alzheimer's disease by one of the leading researchers in the field with Alzheimer's, and he said that there hasn't been a new medication approved for Alzheimer's disease in the last 15 years. And even more so than that, what's worrying is the first case of Alzheimer's was diagnosed in 1906. So in the last 113 years, we can do no more for people now than we could for the first patient 113 years ago, which is pretty scary if you ask me. But on average, a person with Alzheimer's lives 4 to 8 years after diagnosis, but can live as long as 20. So it's highly dependent on the person as well as is treatment. So treatment most commonly begins when the symptoms arise, which, as I said before, is often a decade after the disease has started itself. And the FDA has approved the two types of medications, the cholinesterase inhibitors, which is Aricept, Exelon, and then memantine, which is also known as Namenda, to treat the cognitive symptoms, so memory loss, confusion, and any problems thinking or reasoning. While the current medications cannot stop or reverse Alzheimer's, they may lessen or at least stabilize the symptoms for a limited time by affecting certain chemicals involved in carrying the messages and signaling across the brain.
I'd like to add a couple of things to this, sort of throw in a little bit of like three-dimensional dynamics into it, because when you're dealing with just Alzheimer's or memory loss, it seems like you think, okay, it's just simply memory loss, cognitive function, but the mood there's a lot going on with the mood. So there's also like verbal and physical mood changes that cause them to be a little bit more aggressive, or maybe even less aggressive, or maybe less interactive, right? So in that case, depression, anxiety, anger issues have to be put into perspective, because these are, while we're treating one condition, there are complications of that condition that could be treated with other medications. So there's a whole psychosocial and therapeutic approach to this, and then also pharmacological approaches could be numerous. It doesn't have to be just limited to just the medication specified for Alzheimer's, but the related conditions can also be treated by other medications.
Yeah, and you're right. That's a huge component of Alzheimer's, especially as it progresses. Irritability, complete personality changes. You can have someone who was very reserved and calm their entire life, and then complete 180, irritable, aggressive, violent, promiscuous. It's a huge game changer in what it can do to the brain. And you can treat the behavior with antipsychotics, antidepressants, but believe it or not, a lot of that is actually considered off-label, because you're starting to, as we talked about before, juggling polypharmacy, which can just make things worse at the end of the day.
Right, and then I think people just want to sedate others and not, because they cannot handle certain activities, and that also could be a warning sign as well. So I think, honestly, if this is okay for you, I feel like this is an opportunity for us to discuss, your experience, your personal experience with it, because, I think as a person who's been in the field and has had some experience, can you share with us what you've noticed and how you've dealt with patients who have Alzheimer's?
Yeah, so I was a CNA for about a year. It was an assisted living facility, but we had a locked unit upstairs for dementia Alzheimer's residents. That unit accepted anyone from, just diagnosed to end stage on hospice that we had there. Working there was pretty eye-opening. You have to keep them very engaged, because especially as the disease progresses, they start to revert back to what they know, since their short-term memory has essentially gone. Well, all they're left with is their basic instincts. So we had a nursery on the floor, and more often than not, some of the women could be seen carrying around baby dolls, or changing diapers, or reverting back to what they knew. You also had extreme aggression, especially, I know the term isn't liked, but sundowning was a very relevant problem, towards the nighttime hours. The whole floor would turn over. It would, people would be violent and hitting other residents. You'd have to separate them from one another. It wasn't all the time, but it was a huge factor.
I think this is kind of an important point as well, is that some of the reasonings behind sundowning, which was for me like it wasn't a surprise that I would see that in someone who is developing dementia. For me, the routine and the habits that they had created were automatic in their brain. And so for us, those automatic things happened during the day. And then when nighttime occurred, and especially if they were in an outside of their normal living situation, which typically happened when you were in the hospital, you would then become afraid, anxious. You don't know where you are at, and so that can be very you can be very fearful. And when you're having some confusion and your memory is not good, it just doubles that. And so for me, it makes sense that when you take somebody out of their normal natural habitat, so to speak, that they're going to have some major issues and changes that takes time to accustom to.
Yeah.
In your experience, did you have any scary moments there that kind of had you thinking about, how would you treat or make any changes to how you would treat patients with Alzheimer's? Like, if you're, as a physician's assistant, in the future, are you going to go into that field where you're helping people with that condition, or are you sort of done with that, having gone through this experience?
No, so I've pretty much from the beginning of PA school have said that I love geriatrics and I would love to go into that field, simply because working at a nursing home, that entire population just seems so forgotten to me, at least, and even more so in the Alzheimer's dementia units, because I think one of the most heartbreaking things to watch is a family sitting at the bedside of a loved one who has just passed because of Alzheimer's, and they're not mourning, they don't have that look of grief on their face that you might normally see because they mourned that person years ago. And that results in not visiting them, not spending time with them, because at the end of the day, that patient doesn't remember their own family. So all those people are just kind of left alone. So I would 100% go into that field. But I think... What?
Yeah. No, go ahead.
I was thinking that one of the biggest aspects that people need to take into consideration is ultimately remember where the disease is going. Because when it comes to treatment, yes, you can treat early. You can try and stave off the progression of symptoms as long as you can, which depends on the patient, how much time you get. But it's really for the family, I think, diagnosing Alzheimer's early and giving them the time that they need to plan financially and emotionally for what's about to happen.
This is where I suggest to patients and their family members who have aging parents to find good resources and help, because when that occurs, when that memory loss gets to the point where they cannot even remember, it's very devastating for the caregiver, because that's what connected them to that parent or the loved one, and then they have forgotten that. It could be very hurtful.
Yeah.
So I think that's when the right timing is, when you need to get outside assistance for that, because you find yourself very resentful and hurt by the whole experience, and that is not what your patient or the affected person needs at that moment. They just need someone to help them manage the rest of their time here on Earth, and so I just ask that people consider that and be okay with asking for help. So at this point, we'd like to take a caller. So this is kind of an exciting part of our podcast because we have a caller on line 2, and we haven't had a caller on our show yet. But so line 2 is Martin from Pittsburgh.
Hey guys, this is Martin calling in from Pittsburgh, Pennsylvania, a long-time listener, first-time caller. Before I get to my question, I just want to say I'm a big fan of the Optimal Health podcast. But anyway, so my question is that my grandfather has Alzheimer's, and he's had it now for about 3 years or so. My grandmother has been caring for him ever since the start of his diagnosis in their own home. And it's been kind of really starting to noticeably age my grandmother. My parents are kind of worried that she will ultimately end up hurting herself in some way trying to care for him on her own. So my question is, how do you tell someone that has been married to their spouse for 54 years that their own health, that for the sake of their own health, it's time to hand over the care to a nursing facility?
Yeah, that's an excellent question. I think this is a difficult one to answer because, there's so many circumstances, but I think Shelby, if you want to tackle this one for us.
Yeah, absolutely. No, that is a really good question. It's also a really hard question to answer. And it relates to a lot of end-stage diseases, not just Alzheimer's, is when do you give up that responsibility and put it in the hands of someone else? Mm-hmm. So
maybe I can add this part because sometimes it's just not in your hands. Like sometimes it's just you're not in charge of that decision.
No, and I think at least what I can think that is stopping your grandmother from transferring care is I'm sure there is an undeniable amount of guilt that could be felt. She can't take care of her spouse anymore. Someone that she said from the very beginning in sickness and in health. So there's probably a huge amount of guilt that's being felt. But I think what can help alleviate some of those worries is educating yourself. So if it's time to transfer care, find what you want. Find what you would expect the care for your spouse to receive. So that includes doing a little bit of research, finding out what environment would work best. Can you do home health? Can you do transfer to an assisted living facility, a group home, a nursing home? There's so many different options nowadays. And then also in regards to the guilt aspect of it, is there are so many support groups out there. Specifically, you can look on the National Institute of Aging website, and there is a page-long list of different support groups of people who have spouses or family members with Alzheimer's, and they're the sole caregivers for them. How to tackle that. So I would really recommend that your family and your grandmother seek out those support groups, hear from people who have gone through it before, but then also educate yourself as to where you are ultimately going to be placing your loved one, asking questions, taking tours, visiting, and doing anything you can to make sure that the care is up to par with what you would expect.
Yeah, agreed. It's a hard question, and I think one that needs to be figured out. But that was really good.
Yeah, and I just want to give some statistics on caregiving in general, because I don't think people fully comprehend just the burden that caring for someone with Alzheimer's or any terminal illness can really have on family members, caregivers, friends. So Alzheimer's care costs about $2 billion every year, and that is the equivalent of one of every 5 Medicare dollars. And that doesn't even count the unpaid man hours that goes on behind the scenes in your own home. So Alzheimer's caregivers spend on average 69 to 100 hours per week providing care. Caregivers of patients suffering from dementia reported 46% more physician visits, over 70% more prescribed medications. They are more likely to be hospitalized, and more than 50% of caregivers are at risk for clinical depression. And the reality is within the next 30 years of a large group of people that are 85 or older, one person in that group will have Alzheimer's, and the other two will either know someone with Alzheimer's or be a caregiver for someone. That's just how common this disease is going to become, especially as the baby boomers are hitting or getting older. So, caregiver burden and just the amount of work that caregivers put in to caring for someone is huge, and they need just as much support as someone with the disease itself, because they're the people who are there day in and day out, watching as their loved one kind of dwindles away right in front of their eyes, needing that support, needing that encouragement from other friends and family members.
Yeah, I mean, this is a very hard topic, and obviously you guys can tell that it's one of those topics that, you know, it's a huge emotional, physical, and an economical, you know, burden on society right now. And I think that's one of the reasons why we're so hopeful for some kind of treatment in the future for it. It could take away a great deal of burden on our, you know, on our lives. So I think you mentioned there's some recent updates.
Yeah, so in regards to research, so another staggering statistic is that Alzheimer's research was promised this year a mere $580 million in funding from the NIH. While cancer is slated for more than $5 billion, AIDS is given $3 billion, and cardiovascular disease is nearly $2 billion. So the overall awareness and funding for Alzheimer's research is minimal. And looking at, I was looking at statistics today that on average, the same amount of people die from Alzheimer's related effects as cancer every year. So
how do you think how do we get to this point where, is it because we've sort of accepted it as a possible end for people that this is what happens, and, you know, it's the nature of life, or that's why we're not funding it as heavily, or is there what's the psychology behind the reason why we're not investing as much money into it?
I think for a long time, people have been saying that forgetfulness and memory loss is just a rite of passage for getting older. Mm-hmm. And for that reason, Alzheimer's has kind of been pushed to the side because, again, it is such a clinical suspicion diagnosis. Mm-hmm. There's no yes or no checkbox whether or not you have it from a lab.
Yeah, my theories on that is that it's just about, you know, not economics, but rather marketing almost. To me, it seems like, you know, certain types of disease processes will get certain marketing, focus marketing for them. I'll give you an example, like bone density exams are still, you know, recommended, but they're much lower on the scale than, let's say, screening for breast cancer or prostate cancer. Obviously, you know, cancer is going to be a scary thought, but on the other hand, you know, bone density is important too. So this kind of case, like where you're dealing with a condition like this, I don't believe that we inherently are looking at it with the same eyes, you know, and it's possibly because we're just not getting any good stories behind it, or maybe just not enough good press behind it. And so I'll give you an example. I think Parkinson's, for example, since the Michael J. Fox, wasn't it, who had a great deal to do with educating us on, received a great deal of amount of, from what I understand, financial windfall because of that. And you know, I think it's just something that we need to like refocus our energies on, because obviously it's not only, you know, burdening us in with our lives, just dealing with the emotional aspects of it, but also the community in large,
Exactly. And Alzheimer's, it affects 44 million people worldwide, and by 2050 that number is expected to triple. So we need different treatment options and research out there more than ever. And thankfully, at least I have noticed in the news lately, there has been more talk about Alzheimer's disease. So the most recent being that I found was that there was a huge study done that related dental and cardiovascular health to the presence and progression of Alzheimer's disease. What they looked at was different brain plaque accumulations, and they actually found spirochetes, which are typically known for being related to syphilis, but there's actually a presence of spirochetes in periodontal disease as well. That they showed the plaques contained the same spirochetes from periodontal disease.
Sure.
So they are looking at prevention of Alzheimer's disease through appropriate gum health and dental health screening in that regard. They're also finding that they're trying to find biomarkers that are used in early identification. And there's also a significant research looking at how to support caregiver health. And looking through the National Institute of Aging's website, there are pages and pages of clinical trials going on right now looking at potential medications. The problem with research right now, though, is that the mechanism of Alzheimer's disease is still unknown. A lot of the trials that have been successful in mice or animals, they don't translate to humans. And it's still a problem that we are ultimately treating Alzheimer's too late because the progression of it has started a decade earlier. So what research is looking to treat is the reversal strategies. There's been a vaccine that is being tested but was halted because of side effects. And then any kind of plaque busters they're trying to find research for. And then ultimately generating new tissue via neuroregeneration strategies with stem cells. So that's kind of where we're going, but we need more funding to do so.
Wow, I think that's exciting. Obviously, we do some stem cell in treatments in our office. I'm not quite sure how this would be utilized because we do have some that have been recommended some IV stem cells, but I know that's still controversial. So I do know that we do give the stem cells, for example, for knees or backs or shoulder or musculoskeletal injuries. I'm aware of some people doing IV stem cells for, I would say, rejuvenative properties, but there are also discussions regarding stem cells for diabetes, and autoimmune processes in the body. So there's a lot of interesting updates on that. In regards to the vaccination, I would love to hear more about that in the future. And so if you do hear more, maybe you can come back and tell us if there's any updates on that in the near future. But this was an excellent and very thorough topic. I really do think that, especially with your insight in working in a nursing home facility type Alzheimer's unit. I'm sorry, is that correct?
Yeah.
And I could see how that might have been a sort of it got you into the field of medicine, and now you want to do more for them. I mean, I'm excited and say I'm just happy that you have that inside of you that you would care for others like that, because that's a topic or something that I struggle with. But I don't mind taking care of patients here in the office, but I used to work in a group home setting, and I found it very difficult to relate and take care of people like that. But you have that in you, so that's exciting.
Yeah, thank you. I appreciate it.
So, thank you, Shelby, for another podcast, and thank you, Martin, for calling in. We really appreciate that. That was a wonderful part of our new addition to our podcast, so to speak. And, welcome back anytime. So,
thank you.
This is Dr. Jonathan Youssef, Networking for Your Optimal Health. Have a good day, guys.